Good afternoon, everybody. I'm Dr. SIDDHI SHANBHAG. I'm a junior resident from BJ Government Medical College, Pune, and I'll be presenting an interesting case report, a curious case of PURTSCHERS-like retinopathy. A 33-year-old male, known case of severe anemia, presented in emergency with complaints of burning sensation in lower and upper extremities with decreased appetite, increased fatigability since 15 days. After a panel of tests showed raised HbA1c inflammatory markers in addition to low Hb, a fundus evaluation was requested by the physician. Patient, however, had no ocular complaints. Significant past history, there was history of hemorrhoids for which he was undergoing treatment and which may justify his severe anemia. He was also a known case of chronic tobacco and alcohol use disorder. On general examination, he had generalized pallor, some stigmata of leprosy. Also, on systemic examination, there were reduced deep tendon reflexes. Also, upper limb muscle power had reduced. On ocular examination, the best corrected visual acuity for the right eye was 6/9 and for left eye was 6/6. The other anterior segment findings were within normal limits. Moving ahead, onto the fundus, the media of the right eye was normal. The optic disc was of average size and shape. The margins were clear. The CD ratio was about 0.3. However, there was a generalized arteriolar attenuation. The AV ratio was around 1:4. The foveal reflex was dull. And what is very significant are multiple cotton wool spots around the vascular arcades and a few which are peripapillary and few on the macula, all within the zone 1 of the retina. Going ahead, on the OCT, what we could see is the vitreoretinal interface was normal. However, there were areas of focal hyperreflectivities in the inner retinal layers corresponding to the cotton wool spots. However, the outer retinal layer was normal. The left eye showed similar fundus picture. There was generalized arteriolar attenuation. However, the foveal reflex is slightly better. Again, the OCT images showed areas of focal hyperreflectivities which were corresponding to the cotton wool spots. We did a fundus fluorescent angiography. This is an AV phase photo for both eyes. For the right eye, here we can see we can again appreciate the generalized attenuation of the arterioles. Also, there is the venules were tortuous and distended. What we can see are areas of blocked hyperfluorescence which correspond to the cotton wool spots. Also, there are multiple microaneurysms. The similar picture was seen in the left eye. So we came with the provisional diagnosis of PURTSCHERS or PURTSCHERS-like retinopathy. This was an incidental finding. The patient was already worked up since he had a long stay with the physician. Significant or noteworthy investigations were his HB was 7.2, HbA1c was raised, which was 7.2 again. The SGPT and OT levels were raised, which may be contributed to his alcohol use disorder. Then the CD4 is to CD8 ratio was reduced, but however the ratio was more than 1. CSF analysis showed raised proteins and other parameters. Inflammatory markers were raised, however he did not tick for any autoimmune profile. On pathology, all the biopsies which were duodenal, sural nerve or skin biopsies showed normal to moderate infiltrate of lymphocyte, but no soft tissue disorder or vasculitis could be ascertained for sure. On radiology, there was bilateral upper limb and lower limb motor neuropathy. So, given that the classic picture of PURTSCHERS-like retinopathy, a few leading questions were hence asked, but the patient did not tick for any of these. The management was basically from the physician's side. The rheumatologist opined that the patient might have DME myotrophy, which was again provisional, and he was given a course of IV immunoglobulins 10 gram per day for 5 days. No ophthalmological management was indicated. On follow-up visit, this is after 6 weeks, we can see that the number of cotton wool spots are the same and the size has reduced. Discussion. Now, PURTSCHERS-like retinopathy is a traumatic retinal angiopathy which is characterized by complement-mediated leukoembolization. However, when features of PURTSCHER retinopathy present without a history of frank trauma, we call it as PURTSCHER-like retinopathy. The most commonly seen case of PURTSCHER-like retinopathy is acute pancreatitis. However, our patient did not fall for any of these already known causes of PURTSCHER-like retinopathy. Also, for our patient, what is very important is we kept a close follow-up because sometimes the optic disc pallor and RNFL atrophy can set in. Hence, this is my interesting case, and what is very interesting is that we should look for association between diabetes and PURTSCHERS like retinopathy. Thank you. These are my references.